Two vascular surgeons walk into a bar and come out with a podcast. We are talking everything vascular and not. Welcome to the Life of Flow podcast.
The following podcast is not relating to my teachings and work at Del Cedar Medical Center and is for entertainment purposes only.
Bienvenido or bienvenuti to the Life of Flow podcast, number one healthcare podcast globally. We are hitting the Middle Eastern charts hard this week. For some reason, I don't know why, Abu Dhabi and UAE, we're just on fire.
Let's go.
On fire. Rampant. Anyway, our awesome, cool friends in the RVT world, Abigail Mize and Jill Sommerset, kicked it off with a 1 hour update on just fun stuff about ultrasound, why we should be working together, how can we bring them into the OR, how do we use them in the OR at Hope, how do we decide on how to change algorithms, how to treat, how to intervene, maybe even on how important it is for new clinical research on some novel devices below the knee and how refurbishing the entire industry on ultrasound and the detail of it as a vehicle to impact just better patient care.
So we have to be champions of ultrasound.
We are absolutely Life of Flow, hashtag ultrasound first, hashtag NAA. Look for our merch coming soon to a Walmart near you.
All right, let's go.
Right, bye-bye.
Hello, everyone. Hey, Jill. Hey, Abby. How's it going?
Hey, guys. Good.
Great.
Thanks
nice
for
to see
having
you
us.
all.
Yes.
Jill, repeat offender of the LOF.
I think you are
Yes,
officially
happy to be
the
here.
third wheel.
Do you know what? We have now decided that we're going to have merch that says NAA.
Yeah.
Do you know what that stands for?
No.
No assholes allowed.
Love it.
That's a good rule. That's a good
Yeah.
rule.
Yeah.
Yeah. So I mean, so that just means that we're trying to keep the a-holes out.
Keep it cool.
And so welcome you two non-a-hole people to this beautiful morning. Abby, you are new to the guests. You're to the pod. You're new to our listeners worldwide. We're at about 70-something countries right now, based on manifestation, not actually reality. But it would be, I think, great for the rest of the world to know a little bit about you. We have talked to Jill in the past, and we certainly know a lot about her, but we would like to know about your path. When did you fall in love with vascular? How did this become your journey, and maybe how did you ultimately get so involved with like procedures and what that means?
Sure. Yeah. So my name is Abigail Mize. I'm a dual registered cardiac and vascular sonographer. I originally got involved. When I was in ultrasound school, my plan was I'm going to do ultrasound for a couple of years, then I'm going to go to PA school. That was always my plan. And then when I got into sort of working in the hospital, you see more of what people are actually doing and you get exposure to those roles. And I really, truly fell in love with the technical side of ultrasound. Hated vascular in school. Thought it was gross. I wanted nothing to do with it. When you're a student and you see a wound for the first time, you're like, oh my gosh, this is what the job is? I had no idea, So I had every intention of doing mostly cardiac and kind of dabbling in some carotids here and there. But I actually had the opportunity for one of my clinical sites to see more of the CLI side and to see the procedural side. And with that group of physicians, I sort of got involved in the amputation prevention symposium. That's where I met Jill. And I really got to see more of kind of the wider reach of vascular and what it can mean when you follow kind of more advanced routes. So I was a clinical student there, got involved just as a volunteer, really, really enjoyed it. I enjoyed going to the conferences and hearing about what other people had to say. It was the first time I ever saw Jill give her PAT talk. And I was like, wow, I've never even heard of that. That was, it was a very new concept. Gosh, that was in probably we met in 2013, 2014. And it was such a new concept, but something you don't hear about in school, and it's new and exciting. And so I decided that was the route I wanted to follow. I wanted to learn more about the advanced peripheral, the intervention side of things. And I was lucky enough to land a job where I got to cross-train as a scrub tech, and I got to scrub maybe one or two heart caths. I could bumble my way through a heart cath, but mostly peripheral procedures. And I got to actually cross-train as an assistant while also utilizing sort of the ultrasound techniques that, these doctors were focused on. And my fellow sonographers had shown me, and really got to learn this whole new side, sort of advanced modality of vascular arterial ultrasound. From there, it's just sort of evolved. It's continued to evolve. I've worked in a high volume CLI center. I actually pivoted to research about 5 years ago. So my focus the last 5 years of my career has really been CLI research. I worked as a research coordinator on the clinical side, and then I actually just recently made the jump to industry, and I work as a clinical specialist with Reflow Medical now, overseeing duplex ultrasound. And it's amazing, and Jill and I talk about this a lot, it's amazing to see how a lot of places don't necessarily understand how crucial that ultrasound component can be, not only to the intervention, but pre and post workups. So that's something I'm really, really excited to kind of talk about. And that's something that Jill and I we do a lot of collaborating on. So this is very exciting for me.
Well, and this is why I wanted to have Abby on this podcast, is because we have shared that same passion, but we have a little different journey to, how we got to where we're at now.
Mm-hmm. Very much so. Very much so. And I can't say I haven't done a lot of clinic in recent years, but I still try to, I keep in touch. Jill and I still keep in touch with, all things vascular, and I still try to go to all the conferences, and it's so fun to still kind of keep my hand sort of partially in, keeping the pulse on clinic, and while also pursuing this sort of research and industry side. It's a really fun dynamic for me. So
you have the experience of being in the operating room. We don't really integrate ultrasound, I would say, at all, like very minimally. Like for DVAs, I do flow volumes. That's it. Like for traditional endovascular revascularizations, I don't. Tell me about that. Tell me about your experience on it. I know some of our colleagues in South America use it actively to cross CTOs, which is very interesting. I know that, Miguel, you sometimes do on-table PATs now in your center. So yeah, tell us a little about that.
I get a lot of criticism on my technique, though,
From Jill?
from the bottom.
Oh, wait
Yeah.
a minute.
I
It's
bet.
perfect
You know,
technique.
You will never be as
you have
good.
to
Yeah.
do this to the spectrum.
Yeah, I know. Change it.
Oh, you have to make the sweep be a little slower. Oh,
hey,
God.
we had to work really hard on learning the pneumology and all of the fancy things that we have to adjust.
These
So
hospital laptops aren't the best for that.
Yeah.
that's true. That's true.
Yeah.
I was more involved in the sort of lifetime ultrasound utilization during procedures. So like you mentioned, CTO crossing, I've done a million of those. We were more, so I hear all the time from doctors, right? It's expensive to have an ultrasound tech. It's not reimbursed to have an ultrasound tech. It's not, because at the end of the day, you have to make money to keep a business running, right? And I totally understand that. I was lucky enough to work with doctors who, kind of evaluated it more from the patient outcome and from the staff and physician benefit side of things. So, minimizing radiation for CTO crossing. We did a lot of most of our CTO crossing, I would say, under live ultrasound guidance. SFAs are great for that. You can visualize catheters and wires very, very well. Certain, pedal access, obviously we did all of our pedal access was ultrasound guided. Stent deployment, when you're in kind of a funky spot, you want to try to avoid the bifurcation. Ultrasound is awesome for that. I've demonstrated, kind of flowering the stent at the ostium of the SFA and kind of seating it so that it doesn't jail the profunda. Closure, that's a big one. That's actually the first time, Miguel, I don't know if you remember this, but the first time I ever really knew who you were, you had given a presentation about ultrasound guided all of the closure devices under ultrasound at when we were at AMP in Orlando.
Yeah,
Yep,
that's
I
the
remember
best
that.
talk.
It's the coolest talk, and I saw it on the agenda, and my flight was at 12:30, and your talk was at 12:20, and I was like, I have to watch this talk at the airport.
Yeah.
And we were literally taking off on the runway as you were finishing your talk, and I was like, please don't cut out, please don't cut out. This is so cool. Please don't cut out. But ultrasound guided closure is really fun for me. That's an easy one to teach people. You don't need an ultrasound tech for that, as you've very clearly demonstrated. So yeah, my focus was very much the actual lifetime techniques, and I still teach those techniques today.
But to Lucas, to your point, and I think ultrasound in the cath lab can be so valuable, but I think it's case selection.
Yeah.
You know,
absolutely.
I like to do a pre-mapping in the bay and just verify that, you know, I'm not going to be able to see in the Hunter's Canal because it's a rock pile.
Right.
So I think that there are some limitations to it, but certainly in, you know, there's optimal conditions that ultrasound is really beautiful to
Yeah.
use to its fullest potential.
Yeah, second that. I mean, the Hunter's Canal, it's pretty much a total loss for ultrasound, right? It's the most difficult area to evaluate. TPT, it's pretty much not going to
Tough.
happen. But yeah, recognizing where it can be used successfully and where it's probably not the best option is probably the biggest learning curve, I think, for people who are trying to use it.
If you come from a posterior approach and you frog leg and you disperse up the popliteal, I think you get a pretty good shot from the back. It's a funky position because the SFA goes from the medial aspect into the Hunter's, the adductor hiatus, and then disperses back behind the bone and becomes a popliteal. But I think you could figure it out also even in that by coming from the back. You get a pretty nice head-on shot at that, you know, SFA diving into the pop. And that's something that's important.
I've used it for when you have a flush occlusion of the SFA and you can't really engage or have a clear understanding of where to engage using fluoroscopy. I've used that to kind of see that bifurcation and drive an Estata wire into where the ultrasound's showing me. So, and I found it really helpful for that. So yeah.
Yeah. When you know, I'm a big advocate, period. I believe physicians should be a little bit more proactive about learning it. Just because the resource, to Abby's point before, you know, you don't always have it. And even though I do have it more available at Hope, still, if I go to the hospital and do a case, good luck. And so I really think there's a responsibility to the patient that you use your eyes and ears that goes beyond the limitation of 2D fluoroscopy. I honestly don't feel I can take any quote CLI, CLTI operator that doesn't integrate ultrasound into their algorithm. I just don't take them seriously. I think that there are some things that we do and we say and they become just like okay, and that we accept it. And I've started to try to tickle against it. I'll mention one pretty particular thing that drives me nuts, which is you're doing a live case and they're doing an SFA and they do all this work, and then the angiogram shows something fuzzy, and they're like, well, the good thing is it's not a hemodynamically impactful.
I know.
How do you know?
Yeah,
How do they know?
What the hell does that
Right.
mean? Yeah.
And so, I'll be in the panel. I was like, so how do you determine? I was like, well, the contrast is washing. So you think it's biphasic distal to this area? No, but you know what? You're right. I'm going to put an IVUS in. And I'm like, that's even worse. Like, now you're going to show me something that looks terrible.
Yeah.
Because every time you put an IVUS, you can make anything look terrible. IVUS is like turning the lights on at 3 a.m. at a club. That's it. Oh, no. It's a terrible thing. No, there's no club in the world, nowhere in the world, either Europe or Latin America, where at 4 a.m, those lights go on and you're like, I've been dancing with you. Like,
Yeah.
or even yourself, you look in your mirror, you're like, I thought I looked great. And like, this is what I look like.
Yes.
But that's IVUS, right? It's always going to overcall. It's always going to potentially get you into trouble, but it gives you no hemodynamic information.
Right.
Unless you're doing FFRs and unless you're doing some other more, engaged things, you're not. But guess what does? And it takes 1 second, EVAs. And if it's in the room, there's no reason why you couldn't do that. I showed this really nicely in our last Hendelat live case. It was an SFA long CTO. We did it. We opened it. We ballooned it. And it really looked good. And we're like, yeah, should we stent it? No. And everybody was like, the panel already like, stent, no stent. I said, what about ultrasound?
Mhm.
Everybody's like, it's so difficult. I was like, let me show you. And I literally put the SFA and I gave the waveform and I made it nice and I put the angles right, the basics. And then I went down to the popliteal And I did the same thing. And it was this blunted monophasic waveform. And then I turned around and I said, does anybody have any doubt that we have to stent it at this point? And the answer was just obviously unequivocally, we have to. And that's a thing I think we're missing. I think that we're doing a lot of these things and we're not proving to ourselves that what we're doing from a technical standpoint is hemodynamically impactful. And we just have to get into the habit of doing that. Now, I do believe that despite the fact that I will push all trainees to make sure that they feel comfortable doing the ultrasound, not just interpreting an ultrasound, in America, the reality is that we're going to get there probably easier by integrating you guys into the algorithm, right? I mean, it's just that we're not going to, this is almost like an ethos thing, right? It's just like, this is the mentality of the American business or system, that we have uniquely trained people like yourselves that can help us really, really a lot. And I I don't know how we're gonna do this from a practical standpoint. But I do believe that it all starts with a conversation. And I was actually delightfully impressed. I think I mentioned it to Jill the other day, but I was invited to give a talk to the all the RBTs of Methodists, and it was on like the deep venous arterialization stuff. And I was talking about how flow modulation is important and how I do it sometimes on the table. And so the manager, funny enough, towards the end was like, well, how often do you know, are these like emergencies in the middle of the night, or are these cases that are planned? I said, no, the majority of them are planned. And her like immediate was like, well, why don't you give us a heads up and I'll send somebody down. And I was like, you're what? Because all of a sudden, like, I mean, it's a big deal. For me, it's having a good machine, having, good technique, and then having the images in the packs, right? Because I'm there on these laptops and taking pictures with my iPhone, trying to remember the information the next day. So even though I feel comfortable doing it, what an asset to have somebody that could be. So then I could be like, okay, well, let me change this or drop this coil, do this. Can you check it again?
Mm-hmm.
And the reality is, she was like willing to make it and figured it out. In a hospital system where, there's not going to be any additional.
I do that actually. I let them know beforehand, and they come up at the end, and then they just do flow volumes.
So I'll just say, sometimes we make these stories up without even trying.
Yeah.
That's huge though, especially in a hospital system. The first hospital I was at, there was a lot of pushback because, you're taking a sonographer away from a diagnostic study that is earning the hospital money. And at the end of the day, okay, we miss on 1 or 2 ultrasounds, but you're also talking about the potential of eliminating another procedure for a patient. You're talking, which also is saving the hospital money, but they don't see it that way. They just see the immediate return. So the fact that you have a hospital that's willing to help with that is awesome. You absolutely should capitalize on that. That's great. It only takes one ultrasound tech who's willing to learn a little bit more, and then it just sort of becomes this, waterfall effect.
Well, and I think that physician champion is huge. The physician champion to then, bring that vascular technologist in and teach them and learn is such an asset, like you said.
Yeah, I think people really underestimate like how much the sonographers really do want to hear from you guys, from the physicians. We can talk to each other all freaking day, but at the end of the day, you guys are the ones who kind of are wielding the power here, and you guys are the ones who are driving this change. And so to hear how excited you are for them to get involved is what's going to really spark the excitement in them and the willingness to learn.
And I think this is easier in the OBL setting. A good starting place, because you can just wear lead and scan your patient. And I just jump in real fast, whether I have to go under the drape and look at an SFA, if it's hemodynamically significant dissection, or a quick PAT, and then bounce back and scan the patient. But that takes an ultrasound tech who is really motivated, very passionate, wants to be there, wants to be engaged, not rolling their eyes like, oh my God, I can't do all this work.
Right.
I mean, I crave that. Like, call me, please.
That's how I was too. I was so excited to like get this opportunity to add to, and no hate whatsoever, no disrespect. There are ultrasound techs who, have been ultrasound techs for 20, 25 years, and they love it, and they're very good at it. And we need those people too. But but I was never that ultrasound tech. I needed to get out of that room every once in a while. I needed to go see what else we could do with this. So
The also the added value that you get from unleashing these assets on your patient care path is unbelievable. When you are able to uh, generate that metamorphosis of I'm an individual whose task is to ascertain images and upload, and I'm limited in that scope of practice, to I am part of this team. I'm an integral element of this team, and I can help improve care by A, giving me better information so that we can all take better decisions, but B, activating yourself, involving yourself. One thing that Jill has helped us do tremendously well at Hope is train the techs in precisely that. And I love, it's like an open door policy when I see the techs that kind of peek out and they're like, I need some help, or I think you need to come in. It's like, hey, I'm in ultrasound room 2. You need to come and see something. Like something's off. Because guess what? They are picking up on stuff that I have to do immediate, potential reactions on, right? It's like, hey, there's no flow. Hey, you just dropped a stent. There's no flow. Hey, there's a pseudoaneurysm. It's just the unlimited power that comes from having that flow of information and the understanding that you guys are, in a way, the first to blow the whistle on potential issues, right? You are the eyes and ears.
So whenever you're doing a case in the OBL, immediately do you get a post-procedure full duplex?
No,
No.
like immediate post-op?
Yeah, like in the.
No, that isn't what we do. I would say on a case-by-case basis, if there is anything that I'm uncomfortable with, then that'll trigger me to ask for an immediate. And that could be something as simple as, I want you to like what's happening with my pedal axis. Like I'm not getting good signals distally. Did I occlude the vessel? Is there some sort of bleeding? Something's happening. Is there an axis-related complication?
Yeah.
Or I remember this guy that had an SFA occlusion. We opened it. A lot of work came out, and we couldn't get any signals. Well, the stent went down, and immediately we just turned around, put him back on the table, lysed it, rotorexed it, got it open, got him back out, and it was an immediate reaction to that.
Closure's a big one. We did a lot of closure verification before patients left.
Now, there are a few circumstances where you're seeking hemodynamic evaluation. For example, indirect revascularizations. Jill and I, on the list of 1,432 projects that we are trying to get out the door, have this perineal study where we're looking at trying to objectivize the fortitude of the collateral pathways. So if you have perineal with a robust anterior perforator that then drains into the dorsalis pedis, our hypothesis is those patients have a natural bypass, and you should never do a long AT.
Yeah.
And you should probably just do a short CTO or a short balloon angioplasty of the perineal. But then the question is, you have to prove that. And so some of those are those that we like to actually do.
Pre and post PATs.
Correct. Because we're trying to direct and guide care intraoperatively. Or we maybe do an immediate one where there's some leg races and up and down to create the some competitive flow with changes in the level of the leg that has to do with gravity. You raise the leg, you drop the leg, you raise the leg, you drop the leg, and then you measure them. It's almost like doing an ABI, if you may. And so we've shown you some of these where you're like, yeah, the collateral pathway is so strong that there's no significant drop in the distal pedal acceleration times. Because sometimes you can have.
How does the leg raise So you can have a normal PAT, and if you raise the leg, it's abnormal? Really?
Yeah. Jill, do you wanna talk about that
What
exercise?
do you do with that information?
It's actually really incredible. We're at 41 patients now in our data, but you basically do a baseline PAT and then raise the leg for 2 minutes. And it's like a induced kind of exercise test, not really, but it's just pushing the limits of those communicating arteries. And then I take a PAT as the leg is raised, and it can be stay the same or get worse. But then when you lay the leg flat again, you do an immediate post and see how fast they recover.
And what does that tell you?
The intent is to determine whether the collateral pathways are robust enough to not fall short when doing minimal changes in the level of the extremity. The reason for this was an observation during a study that I did many years ago with the micro-oxygen sensors. And so patients with CLI, we would raise the leg and create a schema. I mean, if you think of that, you've seen that classic sign where people come with pendant rubor.
Yeah.
Right? They're very
You lift the
ischemic.
leg. Yeah.
And people say, okay, well, how do you differentiate pendant rubor from cellulitis and infection? And it's very easy. You just lay them flat and put the leg up, because in a matter of 30 seconds, the very red violaceous foot's going to turn into a pale white foot.
Mm-hmm.
So that alone gives you an idea that happens.
Yeah.
Then we showed it when we had the micro-oxygen sensors. We were trying to identify these patients that with leg raises would recover or not recover the oxygen molecules in their own milieu. And so we used that to then extrapolate it into the PAT exercise, all with the intention of saying, is a single perineal intervention enough or not? Because you hear these rather black and white stances on podiums where people say more is better. Sure. I mean, I'm sure that if you open 3 vessels, it's great, but what about radiation to the team? What about contrast? What about the fact that you sedate a patient for more than 45 minutes and you lose the battle because they're all over the place? So there's all these other reasons to say, if we can do one vessel intervention that is successful and you can prove that there's a success by a hemodynamic stress that leads to show that one vessel is collateralized enough to the metatarsal artery, then you can probably secure your results. And so that, for example, I feel is a huge component of what having a tech in your lab that can do all this. Because you may be, all right, let's go, I'm going to be doing another case. I want to know that. Now, the tricky part of it, I think, is that when you first open them, you don't necessarily get that response. Like, it has to kind of, you have to recruit the collaterals and then you can stress them. So sometimes we just do it outside and then decide, okay, we may have to come back. Of course, the best case scenario would be, let's figure out how to do this on the table and then react immediately to that. But we could probably do that with nitro. I was thinking about this. I could probably give the patient 200 micrograms of nitroglycerin while having the tech do a PAT, and that would be the same effect, because by vasodilating the leg, you would measure essentially the drop in PAT. So 200, 400 micrograms stress, and then see how much it hits, and then see how it recovers. Then you could potentially get an on-table of what we do off the table with the raises and lowering.
The problem I've had with, especially with flow volumes on table, is the sheath. Is that the effect of the sheath? So I could see how that can throw you off in either doing more or doing less. So yeah, what do you think about that, Joe? Especially if you're doing antegrade access, which you do most of the time, I do most of the time. You can't really pull back that sheath and measure.
Yeah, I think there's a method to this, and we wrote about it in the Endovascular Today journal. But we take a PAT pre-procedure.
We did.
You
about this, about the sheet. Where is it? What journal of endovascular? No, journal Endovascular Today.
Endovascular Today. Yeah, yes. It was the efficacy of PAT on the table. So we take a PAT pre-procedure.
We'll put it in the show notes for everybody.
Put in the sheath. Mm-hmm. And now you have a new baseline. and you know the delta. Because if the PAT is 200 and you put in a 6 French antegrade sheath, the PAT is going to maybe go up to 250. Now you have a 50-point delta that you have a new calculation that you need to take. So now you do this intervention and the PAT drops to 150. Well, when you pull that sheath, it'll go down to around 100.
So you're saying you grab a new baseline after you get access.
Absolutely.
Yeah, you reset it.
Yes.
You guys have correlated that actually, because theoretically, yeah, but
Well, again, at all observations from the same exercise. So when we would do this micro-oxygen, the company was Profusa. And if there's somebody there with money somewhere in the world, go buy them. I think that they have some really good technology. Anyway, we would put these sensors in. We would inject 3 sensors in the foot 48 hours ahead of the procedure. And so we would get these really nice signals of oxygen. We'd put the reader on the foot. And then when we started aggregating the data, within 1 hour of the procedure, everybody would just drop to the ground. And I was like, what the fuck is happening?
the oxygen levels would drop within
on
1 hour.
every single patient.
Really?
Yeah. And so I'm thinking, okay, well, is it the temperature in the room? And we start thinking about this thing. It's a fucking sheath. The moment you put the sheath in, everybody's oxygen tension goes down because there's a big obstruction to flow within the lumen of the vessel.
Yeah.
And so, when we were looking at this, I said, we have to consider that. Can you validate my observation? And literally like 2 weeks later, she came, such a good student.
And I think that validates.
She came back and she's like, the fucking sheath. Well, you didn't say that. Well, maybe you did. I'm not. You're always so proper. But she said the sheath definitely. Like the PAT drops. It's immediate. I can see it. I was like, okay, well then there's your course correction, right? That's how you can say, if my delta is 20 or my delta is 80 or my delta is 100, then reaccommodate your numbers starting, and then use the numbers you get to then go back and decide, am I done or not? Yeah. The problem is we have to just figure out how to do it easily. That this is not going to be practical. As much as we'd love to have everybody there on the table, we have to be able to have a device that could just do that.
I think that what you just said, that the sheath, drops the oxygen tension significantly, also speaks to a point which you taught me, which is getting it out quick. Like, don't spend 6 hours doing a case, because that also means that you're creating additional ischemia for 6 hours on a already ischemic foot. Yeah, man. I remember Vanita Chandra. Yeah, the years ago I was in a course and we were doing this bidirectional approach, and they were all. I remember Vanita was starting, and Harachi was starting, and Tim was starting. All these guys that are now amazing in their own fields, which makes me feel super old. But I remember we were in this course and it was like bidirectional and pedal, and they're all like fumbling with getting the axis and learning. It was pretty early stage. And at some point it was like, okay, well, how much block time do you set for these cases? And I said 2 hours. And I remember Vanita like laughing out loud. She says, there's no way you can do a case like this in 2 hours. I was like, yeah. And that's what you should probably give yourself. If you're in this case, it doesn't matter how hard it is. You're in a case stuck for 3 pushing on 4 hours, something's off. Yeah.
Something's off. 2 hours, 3 at maybe the most.
At 2 hours, you should see the light at the end of the tunnel.
Reconsider. Yeah. But if not, then reconsider, right? Come back, have another plan, bring more people, bring your friendly tech in the room and have him help or her help you. Because something's off. You're either on a weird dissection, you're in a weird place, something's not working, something's not clicking. You gotta, I don't know, you gotta figure it out some other way. How are you gonna get past? Okay, well, we can try to work on the physician champions, and I assure you that anybody that listens to this podcast is gonna be like, yeah, I want a tech in the room, right? But I feel a lot of it also comes from education, I was about to say, we get students. We're involved in one of our previous techs, who is an ultrasound teacher, has started a rotation with us, and I get all these people. and they are all completely unaware of, I even pull them in and I'll ask them, there's not even a rotation of even intraoperative anything. And so that seems like an opportunity waiting to happen, is find some of these RVT training programs that would allow us to develop.
How long have we been talking about this, Jill?
Right. I was going to say the same thing.
Jill and I talk about this all the time. I have a bachelor's degree, and I never stepped foot in a procedure room except for at my one clinical site. And I wasn't allowed to go in the room. I had to stay in the control room. I had no idea what was going on in front of me, right? Because we don't talk about that in school. Ultrasound programs are the same as any other, allied health program. They teach you how to do the thing, and they teach you how to use the machine, and they teach you about pathologies, but they don't really teach you what those applications, what the implications are of that. So we talk all the time. I do a lot of physician education, and I do some tech education if the opportunity arises, but it's really hard to organize sort of a larger scale tech education program. Some of the conferences have it, which is awesome. But they're definitely, especially now as this is, continuing to grow, obviously intervention is still continuing to progress and will continue to progress. I think that there's absolutely a need for the societies to get involved with this and say, hey, this is something that the physicians really are valuing. If we can provide some sort of basis for these students to then go out in the world and seek out, the facilities that are really utilizing this well, I think that is the start.
Why the societies? Why not just do it yourself? There's things called Kajabi, there's things called Maven.
What are these things? Sorry.
There, where you do online courses, like that's where Courtney does a lot of her courses. So why, if you wait for the society, you'll be waiting until you'll retire. So we just have to take action ourselves. We could do I think there's a huge gap for physicians. The amount of what percentage of physicians do you think can do a reliable waveform on an SFA to see the dissection flow?
Under 5%.
Under 5%. So there's the gap. So how about we put it up on ourselves to use this platform and to set up a online course? And that's easy. Fill in the gap. I don't want to hear about the SVS. I don't want to hear about the society for whatever.
SVU.
The whatever.
SVU. Society of Vascular Ultrasonography.
Yeah, I really don't want to, it's pointless to have to catch up.
I think to your point, Lucas, that's what a lot of us are doing. I mean, Abby, you do your own consulting work. I do my own consulting work. This is how we're trying to move the needle to get, advanced ultrasound education. But to all the listeners, if you're interested in having an ultrasound tech in your cath lab, I think the first step is to invite them in and watch a case that they scan, that they can see the correlation or the miss and learn from it. And, you learn a lot by standing in the case, watching, listening to the physician speak out loud about what they're seeing, what they're doing. And I think that's a great starting point.
Yeah, I think the physician collaboration piece of it is going to be, that's what's going to make or break a sonographer's experience in wanting to learn more. Because if you've got, especially in larger systems, you've got a lot of separation between the OR or the cath lab where the physicians are doing the procedures, and then the ultrasound department is, sometimes it's in a different building. So there's a lot of separation, I think, and it really, that physician champion is what's going to sort of continue to shift this. You have to be willing to go make the trek over to the ultrasound techs and find one that wants to learn and, explain to them what even happened in the procedure. You'd be amazed at how many ultrasound techs have no idea what happens in your procedure. They don't know the difference between a catheter and a stent and a balloon. They don't know what any of that means. So you're talking about really rudimentary information for the physicians and for the cath lab staff, but the sonographers have never been exposed to it. So there's a lot of components to it.
I think there's a method to this madness of a protocol of how we pre-map these patients to go into a procedure. And it'd be really interesting to get your take, Abby, because when I teach it, it's like a 10-minute fast ultrasound. So I'm looking at access safety and thinking about closure, whether it's groin access, pedal access, radial access. I'm looking at the cap morphology. I have my skin marking pen that I'm going to mark where the cap are. I'm going to look at
Gillogram. Is that what Mary calls
on
it?
The leg. I'm going to look at vessel sizing. I'm going to look at, how am I going to be able to see, wires and catheters as we're crossing. I'm going to obviously do PAT, and then I'm going to map that GSV real fast and if the disease pattern fits, I'm going to map the lateral plantar vein. So in my mind, I'm trying to think steps ahead of the physician.
Yeah, I completely agree. I think that there's especially now with, the more and more that we move into CLI, truly focusing on CLI and it being kind of the separate treatment from traditional PAD patients, the duplexes and the workups are not the same. A CLI ultrasound truly is an advanced arterial duplex. It's not a baseline arterial duplex isn't going to do it anymore, right? Scanning. I tell people about my very first job. I worked in a big hospital in town, and their arterial duplex protocol was so minimal. It was like common femoral, prox distal SFA, distal tib 1 and 2, and that was it, because they didn't really focus, and that was the bare minimum at the time for the accreditation, and they didn't really do a lot of focus on it. So then when I moved to these other places that do truly CLI evaluations, it's totally different. And then you bring in that procedure education component, and they're aware of what happened in a procedure. That completely changes the way that they perform their duplexes, because now they know what you're looking for. They know what you did during your procedure. They know what the potential issues could be. And it really kind of changes the dynamic of going from just a traditional diagnostic arterial duplex to a CLI patient workup. There's a huge difference. And I think that mindset is luckily growing with, Jill has done a lot of education. I try to do as much as I can. And there's a lot of people out there like you guys who are, trying to really, we're trying to get the word out that it really is different.
It's very comforting to see more and more attention to detail when it comes to ultrasound below the knee, below the ankle, and data and research. When you think of why we're here, in a 2025 with absolutely no progress technology-wise on the below the knee vessels that's FDA approved, that multiple other countries in the world have approved. The reason for that was flawed trial designs and flawed ultrasound endpoints.
What technologies are you talking about?
Any attempt of BTK technology has failed miserably, right? The only thing that came through was this bioabsorbable stent. And it's because it was made with much improved ultrasound endpoints. For example, I forget the DES stent that Boston tried to push through. Remember what was the... anyway, it was like a mini alluvia.
Oh, so you're talking about the Saval trial.
Thank you. Saval, S-A-V-A-L. Okay, well, the definition of patency was ones and O's. Like, it was there's either red blood cells going through this stent or this lesion, or there's none. There wasn't any detail as to hemodynamics. There wasn't any detail as to waveforms. And so, of course, if you use that, that depth or lack of depth in the characterization of the lesion morphology and the way that the lesion responds, then of course you throw a stent against the POBA, there's going to be absolutely no fucking difference. You have to look into the detail. If you're trying to prove that a scaffold improves patency and results, then you better make sure that ultrasound is performed by a really good person, and that the ultrasound goals that have been set from an objective standpoint are those that will actually tease out patent vessels versus highly restenotic vessels. So essentially, you know what I'm saying? Like, there was this really brute cutoff. And so we lost the opportunity of having a technology that could have potentially improved patients' lives because of a poor ultrasound definition.
You're saying that the ultrasound evaluation didn't pick up like a stent that had restenosed significantly and just categorized those stents into occluded?
Yes.
Okay.
And it's in the same the other way. So, a POBA lesion that had 95% stenosis, but there was 3 red blood cells going through it, kicked the ass of a triphasic waveform of the stent.
Oh, so they didn't look at the waveform post-op.
There wasn't any degree of true in-depth ultrasound analysis. And it was one of the things we had Mike Jaff on the show, and Mike and I very confidentially spoken about this. And, I can't share the details, but I would love to look at that data again. Fortunately, the company has made a decision to, kind of tack the project and move on. But I wouldn't be surprised if I would just look under the hood of that data and go and pull all those ultras, and I would find a absolute signal of difference. PULBA versus a drug-eluting stent. Come on. There's multiple randomized controlled studies that have shown that that's absolutely different in patency. But when we have poor endpoints and poor understanding, and half of the techs, if not more, of techs in America barely go under the popliteal, or if there is anything such as a 4x4 on a wound, they run away.
Yeah.
That's funny that you mentioned that, because in my capacity now, I'm a clinical specialist on the clinical affairs team at Reflow. So I'm the ultrasound champion for our research team. So, and it's amazing to me how many people don't understand. My job is to teach them the protocol and to teach them what images we need them to obtain, for the target lesion. And half of them don't even know what target lesion means. I mean, it's amazing to me how I think there's a huge lack of understanding. Again, it goes back to the same, they don't know the procedure. They don't understand how these devices, come to development. And so it's exciting for me to hear you say that, because that's my job now. And I'm really, trying to.
Honestly, a multi-billion-dollar potential enterprise falls on your shoulders. No pressure.
Great.
And I'll tell you why, because we had your boss Isa Risk here.
Yes, he's wonderful.
We had a conversation, and guess what? They have this technology that is called the spur stent, and this is a scaffold. Yeah, it's a scaffold that you balloon open. The scaffold has penetrating items that goes against the wall, penetrates the wall. Then you deflate the balloon, and the scaffold stays on for a few more minutes as there's actual flow to the vessel. And then you drop the scaffold down and you take it out. Well, why is this so? What is so unique about this? There's this entirely novel concept of a temporary scaffold. But why is that so unique? Well, because you can actually code as a stent. And at that point, there's silence. So you're telling me that I can use a CPT stent that pays better, that could potentially influence me to do this, but that there's already CMS approval or agreement that this is a CPT, that I can use. And the answer to that is yes. But here is why it's so important that you do what you do, is because you have to prove to me that you are creating a stent-like result without leaving a stent behind. And the only way that you can prove that is by having some badass ultrasound endpoints and some really solid ultrasound endpoints, which I find incredibly unique, because we are going from I's and O's and terrible data and nobody caring, and some people saying you can't even decide, their tibial vessels can't be seen on ultrasound, to now potentially a large portion of a disruptive technology that is hinging on whether or not there is enough class effect to substantiate A, coding, and B, potentially a novel tool that we all have to start using. It's a huge responsibility on your shoulders.
Yeah, I've done several, clinical trials for devices, and I don't think people who don't do peripheral research don't understand that they're all relying on ultrasound, right? Patency is always evaluated with ultrasound. So it's amazing to me to, you get these ultrasound techs who don't do a lot of peripheral research, or even facilities that don't do a lot of peripheral work, period. And so they just do this normal ultrasound. They're like, oh yeah, here's what we got. And we're like, right, but you still have to focus on. They just don't understand it. So it's definitely been a huge undertaking for me, and it's been really nice because I get to still, talk about all the ultrasound, and hopefully our investigational device will get, approval with all those things. So it's definitely eye-opening to see things outside of the scope of being so involved in CLI for so long, that you kind of get a wider view to see where the pieces fall.
Yeah. And it's actually not that difficult. like the first move, I feel like it's just, it is difficult to make this move, but just have the ultrasound tech do ultrasounds in a room close to you when you're doing clinic.
Yeah.
That is just that alone, just it's 10x the amount of communication, 10x the amount of learning, just like integrate that into, and then just like, yeah, they'll feel like they can come and you can actually see a patient and say, actually, let me just take you over to the ultrasound room real quick. Let's take a look at this really focused problem. So
But you should see, man, the discussions of our, so I hope there's the operational meeting on Monday morning, but then there's a clinical clinical operations meeting, and it's all the clinical staff.
yeah,
The level of discussion and the involvement of the techs is just far and beyond. Like, it's so good. I was like, why are you guys making this? Because also, with this whole PAT thing, there's a few, unsaid rules that still have to potentially be written. But like, what if I have a wound that's like 6x4, but there's 3 of the PATs around the wound are 1, and then 1 of the PATs is 3. Like, is it a 3 or is it a 1? And so I have all these people, like the podiatrist, saying like, oh, you got to like revasc because it's a PAT class 3. Blah, 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 blah. I'm looking at something different. So, hey, Lisa or Victoria, go. What's going on? Like, what did you find? Blah, 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 blah. And then we're talking. I was like, done. I'm not touching that patient. I don't believe there's one PAT of 3 around like 300 ones of PAT class 1. It's fine. You do your job, Dr. Lipo. Offload that patient appropriately. So do some like Santal, whatever you need to do, and stay away from my side. But like, I'll just say that the conversation is just so rich when all these people are working together, collaborating together, talking together, and then there's a mission, and then everybody knows the people, right? And then
Yeah.
you move from, then King is not King. King is not, is not, your third ultrasound. It's Mr. King, and you know what he's going through, and you know what's been happening with him.
Yeah.
And it's a journey, and we're all in this, and we're all committed.
Yeah.
And it's very interesting to see that, right, Jill?
Yes. But you've made that environment, and I think that's huge. You've given ultrasound techs a really strong voice, that they are part of the team, and that doesn't always happen in a lot of institutions. They're very isolated. They do their study and they move on. One of the things we did at a small community hospital for 10 years is every Friday we covered cases, and it was a roundtable discussion with the vascular surgeons and the techs. And that's how I learned to think like a surgeon. And I think that what you've developed at Hope and that sense of community involvement is amazing.
Yeah, I second that. I think when ultrasound techs feel like they're a part of the care team, you're gonna far and away get someone who wants to learn more and wants to know more, and that's ultimately how you get the techs to learn these techniques.
Talk about how to move the needle. You were asking Jill at some point a few months ago, how do I start this whole thing? And Jill pointed out this is like, start with a meeting. Do a CLI, once a month maybe. In each one of your communities or your hospitals, if you feel that you're moving mountains, start with something easy. Do a case review once a month and open door policy. But make sure that you carve time to your techs. Make sure that your MAs come. Make sure that the social workers are involved. Make sure that the that the ortho guys and the podiatrists and the ID and maybe the ICs and whoever wants to be there, that they're involved. And just go over cases. And you'd be surprised the amount of barriers that you can overcome by just starting to show intentional work to be more collaborative, right?
Yeah.
And so, I mean, that may be a nice way to send a message of everybody out there interested, saying, man, I'm never going to be able to do that. It's impossible. I'm in this hospital. It's so rigid. Okay, well, you know what? Start one meeting a month, 1 hour. Try to baby steps, right? And then you carve your way.
Yeah, and I would also say, if anybody is listening and interested in having an interventional ultrasound tech, Abby and I are more than willing to have the conversation and kind of share some of our experience and protocols and pearls for success.
Yeah, absolutely.
Awesome. And these guys are always on the road.
I know. They're always traveling the
They're
world.
always traveling
I'm
the
so
world.
jealous.
Follow them. Jill did an amazing job in Tulum not too long ago, giving both her talks and my talks.
I want to go to Tulum.
Yeah, I might have to go to that conference next year.
You
That
make
looks
sure,
awesome.
Jill, make sure you invite Lucas next year. You can take me off.
Yeah.
And make sure you
I'll go to Tulum.
make sure you give him the
don't worry about
pointers
it.
on how to write his disclosure forms to avoid
That's
getting into
right.
trouble with the University of Pennsylvania Gestapo.
What? Oh my!
Story for another time.
You always get in trouble.
I
You
have a problem with authority. It is what it
always
is.
get in trouble.
It's your girlfriend says it's Hispanics.
I don't know what to say about that.
All right, guys, listen. This has been 1 hour of beautiful conversation. We always love to have you on. Abby, welcome.
Thank you.
Should this be your home, and the light will always be on. If you have anything cool to share, let us
Thank
know.
you. I appreciate it.
What did Scott Cool Dude say that we should say in Mandarin?
Oh God, I don't know. It's essentially
May
may
the
the winds
wind
blow behind you,
behind your back.
kind of
or
like a
carry-
proverb in Chinese. About
I'm not gonna try to say it's Chinese. I'm gonna get canceled.
I would just say pura vida.
Yeah,
pure
pura vida.
life. Love.
Yeah.
Good energy.
All right,
Cheers.
guys.
Thanks for
Thank
having
you
us.
so much.